All right, so we're going to go ahead and get started. Thank you so much for your patience. Someone said that y'all didn't give up on us, and I said, well, that's because you're all public health nurses, and public health nurses never give up on anything. So it's amazing. We greatly appreciate that. My name is Connie White, and I am at this minute filling in for the head nursing position since the retirement of Joy Hoskins, and I'm trying to continue the webinars and the meetings that we're having as the department looks for a new person to fill that position. So I don't want to take any more time, but I'm welcoming you. It's not an ITV anymore, although that's something that we're very used to. It is now a webinar, and I wish that wouldn't keep showing. So I want to turn the meeting right now over to Troy Cunningham. Here. Sorry, don't have my reading glasses on. And we'll get started. Aaron had to leave to go take another call, so we are going to, I don't know how you keep that from, don't show this again. There we go. So we're going to get started with Troy, and she is delaying her vacation to be here with us today. So let's turn it over to Troy right now.
Good morning, everyone. We're having an exciting flu season again this year, so I'm going to jump right into it because I know everyone's busy. Compared to last season, we are actually up on cases. You can see that last year for the entire season we had 10,489. As of the report that will be released tomorrow, there's actually a change in those bottom numbers to reflect this week. As of week 7, we have 10,579 total cases, so you can see we're already above our season total last year. However, we only have 23 outbreaks, and where last year we had 102. I have no idea what that sound is. The number of pediatric deaths we've had this year is 1. Last year we had 4, and the number of adult deaths we had last year were 147. This year we have 24 with a total of 25. Last year we were looking at a total of 151 at this time of year. So we know that flu is spread by the respiratory transmission of the virus and viral shedding, but one of the things that we need to focus on is fomite transmission. And flu can live on surfaces for 2 hours or more. So just because you haven't seen someone sneeze on something does not mean the virus isn't there. So you want to make sure that you wash your hands. Okay. So any doorknob, any surface that you come into contact with potentially is contaminated. So washing your hands is your best defense. Sorry about that. So it takes about 2 weeks after vaccination to get protection. You can't get the flu from the flu shot. If you do have a response, it's actually building antibody response. So it can be a good thing, although people might think that it's that they were actually contracted the flu, or they could have already been infected because you have that 2-week window. As long as flu is circulating, you can still get vaccines, so we're encouraging vaccination as we speak. We want to make sure that you cover your nose and mouth with a tissue or the bend of your elbow. You wash your hands at least 20 seconds. If soap and water is not available, you can use alcohol-based hand rub. Avoid touching your eyes, nose, or mouth to prevent the spread of germs. And if your doctor orders antivirals, please take them. So activity recommendations, it's something that we need to stress, is if you do have flu-like illness, you need to stay home for at least 24 hours after your fever is gone, and that is without the use of fever-reducing drugs like Tylenol or Motrin. When you're sick, limit contact with people as much as possible. Don't go to Walmart. Don't go to your kid's basketball game. Don't snuggle with your sick child if they're as much as you want to. You know, don't stay on the couch and infect everybody in the household. Keep yourself quarantined or the sick one in their own separate room. Make sure that any bed linens are not transferred from one room to the other. Take them directly to the washer, and that's particularly important when we're dealing with long-term care facilities. We don't want to transfer that virus from room to room. So this year there were 2 strains in the vaccine that were changed. One was the AH3N2, which was the predominant strain last year, and the influenza B Victoria lineage was changed. H1N1 was not changed. And the quadrivalent has the 2 A strains and the Victoria lineage, and then the quadrivalent also includes the Yamagata. So preliminary reports this year have just come out last week and are showing that the vaccine effectiveness this year overall is 47%. 40 to 60% is what the target goal is for the CDC, and so we're feeling pretty good about the vaccine this year. Overall, last year it was 40%. It was rumored that it was only 10%, but that was actually the H3N2 virus, and that was the effectiveness in Australia, not in the U.S. It actually ended up being about 25% in the United States for the H3N2. So where we fall short is children. And I can tell you that as of yesterday, 38% of our 10,579 cases are in children ages 1 through 10. And so we really need to get those children vaccinated. I've had reports of children as young as 2 weeks old with flu, and you can imagine how bad you feel when you get it. Just imagine a baby. Of the children that died last year from flu or flu-related causes, 50% of those were healthy children. And of those children, 78% were not fully vaccinated. So that is a big problem. The vaccine effectiveness of this year's vaccine so far from 6 months to 17 years of age is 61% effective. So you can see that it definitely responds well for the children. Vaccine efficacy for 18 to 49-year-olds is 37%, and for those 50 and over, it is actually somewhat disputed. It's because there wasn't enough people registered or enrolled in that study. Okay, and this is a graph that shows you just what a difference there is between that 1 to 10 ratio age group versus the elderly. Now, most of our deaths are occurring in the elderly. We've been very fortunate this year that we've only had 1 pediatric death, but all of our deaths this year have been in people with multiple comorbidities. We've not had a single person yet that was completely healthy. One other area that we fall short are pregnant women. Overall, only about 49% of pregnant women receive their flu vaccine. As I said, we have cases of babies as young as 2 weeks that have contracted flu. If a pregnant mom gets her flu vaccine, that provides immunity to her child up to 6 months of age. So a lot of those could be avoided in those babies if mom just get your flu shot. We know that the provider has a big role in whether or not pregnant women get their vaccine. If the vaccine is offered and administered, it's 66.6% of pregnant women that receive it. If it's recommended and not administered, it goes down to 14.4%. And if it's not recommended at all, it's 19%. So it is, it's very important that if you have somebody come into your clinic, that you offer and administer the vaccine. And please try to encourage your OB offices in your family practice, if you have someone's ear in those offices, to do the same. Another big factor is healthcare workers. We fall far short on that. Overall, the vaccination of healthcare workers is 78.4%. The Healthy People 2020 goal is 90%. The lowest work group of people as far as vaccination are your CNAs and your aides. That can get down as low as 40%. Again, your target is 90. And long-term care facility employees vaccinations are on average are about 67%, and they are the lowest group in vaccination as well. And so we just encourage you to get your flu shot, make sure everybody else gets the flu shot. And, you know, we are seeing a higher prevalence of cases this year, but it is less severe. There's not as many outbreaks, not as many deaths. And hopefully we'll keep it that way. So I appreciate your time. And if you have any questions, please feel free to get in contact with me. Y'all have a good day.
Thank you, Troy. Okay, next we're going to go right to Julie Brooks, because Julie just got called to the legislature, so she's going to have to leave here in just a second. So I hate to get off kilter here, but we're going to go ahead and go to Julie next. And if everybody could mute their line, we've got some background noise, and I'm afraid to touch any buttons because I don't want to destroy the connection that we have. So just be sure everybody's got their computer muted.
All right. Thank you all, and thank you, Dr. White, and thank you to Amanda for letting me jump ahead. As she said, I found out this morning that I have to be down at the Capitol at noon. So, and I'm going to try and work this. So Dr. White had asked if I would do kind of a brief presentation on regulations, the legislative process, and as you all know, the first part of the year, the first couple of months of the year, is the legislative session for the General Assembly. So I am going to briefly walk you through regulations, because as the regulations coordinator, this is what I know best, but then also talk about what's going on currently with the legislator, touch on some things that may be of interest to you. So, and I will preface this to say that I actually took the first couple of slides from the Cabinet's Office of Legislative and Regulatory Affairs training that they had done. I figured, why reinvent the wheel? So this information is not necessarily my information for this part of it. As you said, this defines what a regulation is, and Kentucky has actually a statute, which is a law, that kind of lays out the regulatory process. So regulations are kind of those procedures for programs. What it describes the organization, it may go into kind of practice requirements. It doesn't contain suggestions. It may not always contain best practice, but it does describe how a program will be implemented. The statute, there is a difference between statutes and regulations. Statutes are actually law. Those are required to be passed by the General Assembly during a legislative session. A session usually runs from January to March if it's a short session. If it's a budget year, which is done every 2 years, then it goes into April. A bill is that proposed legislation. So Outside of the legislative calendar, senators and representatives can be filing what they call pre-filed legislation, which are kind of placeholder bills. The pre-filed legislation doesn't necessarily have to be what gets finalized, but it is something that may go on to become law. And statutes are where regs get their authority. And I always kind of give it this example is that a statute gives the program the authority, the reg tells people how that program is going to be implemented. Statutes can contain permissive language that regulations cannot. For example, this morning we were meeting with a representative and a senator to talk about some changes in a statute, and that statute's actually going to contain the includes but is not limited to language, whereas that language is not allowable in regulation. And then again, you have your regulations. Those are known as KARs. With statutes, it's usually, as you can see with this first bullet point, a statute is a KRS, and that always comes first before the number. However, a regulation, the KAR comes second. So most of public health regulations are a 902 KAR Chapter 10. So in the 902, when you're looking at the list of regulations, the 902 actually designates that as a public health regulation. So, again, I said statutes can be very broad, and this is how it's supposed to work. You're supposed to have the statute, delegation to the agencies, and then down to your administrative regulations. Again, it gets very specific when you get into the regulations. So, there is a pre-filing and a filing timeline for regulations, and regulations can be changed at any time. It starts with a review from program staff. Currently, there are 40 regulations that are being in process with Department for Public Health staff. That means that at least something has been done. We've talked about draft language. We've talked about what we want to include, what we want to take out of the regulation. Once we kind of settle on that language, the regulation has to go for a 5 working day internal cabinet review. This means that the regulation is sent out to other cabinet or other program regulations coordinators. They send that on to key staff. Here, when I get a regulation from another program, I will forward it to division directors, some other key staff within the commissioner's office, so that everybody can look through it. This also helps for to make sure that a reg, say that the Department of Medicaid Services, if they're putting forward something that it's not in conflict with the DPH regulation or practice. Recently, we actually had a situation where Medicaid had sent a reg forward. I had sent it on to division directors, and Joy Hoskins had actually had some comments and questions. It was the family planning program that would affect that program. So we were able to meet, kind of talk about some changes. That actually was really key before the reg gets filed, because once it gets filed, it gets a little bit more difficult to change the language in the reg. It does go through other entities. As you can see, the Office of Legislative and Regulatory Affairs reviews the regulation. The Office of Legal Services reviews the regulation. It goes into the Cabinet Secretary's office before it's filed. It also goes over to the Governor's office before it's filed, so that if there's any changes in the language that the Governor's office wants put into the regulation, that can be done before it's filed. Regs are filed, if they're filed before noon on the 15th of the month, and it doesn't matter what month it is, then that starts the public comment period. The official public comment period will be the month following filing. However, once it gets filed, we send it out to key stakeholders. We have 5 working days to send it out to interested parties, send it out to individuals on the Reg Watch list. That's hard to say. So that they are aware, it's that level of transparency with this, interested individuals throughout the Commonwealth. they're aware of the changes that we're making. Again, the formal comment period is the month after filing. There is a public hearing that's usually held toward the end of the month, usually the first Monday or the last Monday of the month, depending on if there's a holiday at that point or not. When someone makes a public comment on a regulation, the program has to do what's called a statement of consideration. And even if the comment's positive and someone says, we love this change that you're making, we think it's great, the program still has to consider that regulation and draft a response. If it's a comment that someone says, well, I don't like this, I think you should make it this language, we don't have to change the language in our regulation, but we do have to consider their suggestion. And if we're not changing our regulation, we have to draft a response back that says why we're not going to change the regulation. It's very rarely do you change the regulation, but it does happen, and it does give the public that opportunity to have comment on your regulation. So once it's done, and the statement of consideration is completed, everything's good. There are 2 legislative reviews that have to happen. There is a administrative regulation review subcommittee that is what's called a joint committee, which means it has both senators and representatives that sit on it. It's co-chaired by a senator and a representative, and that legislative body reviews the regulation, and that's their opportunity to ask questions of program staff. It can get a little nerve-wracking because you never know what they're going to ask, but that meeting is always held, and program staff have to always attend that meeting. If someone doesn't attend that meeting, then the reg gets deferred to the next month, and if someone doesn't show up at that meeting, the reg just dies. And if you've put a lot of time and effort into drafting a regulation, which some of them can take years to actually get to the filing point, you definitely want to make sure that you're at that table so that your reg doesn't die. Then it goes to a second committee, typically the month after the administrative reg review subcommittee meeting. That second committee is when the session's not occurring, it's an interim joint committee, and typically Department of Public Health regulations will go before the interim joint committee for health, welfare, and family services. Much like the reg review subcommittee, this is made up of senators and representatives. It's an opportunity for them to ask you questions. It's also, and both of these committees, legislative committees, are another opportunity for a public comment to be made. Oftentimes, that's at that level, that's where you're getting into associations. For example, the hospital association may want to come make a comment on a reg that impacts that entity. If that committee doesn't meet, if the second committee doesn't meet, then your reg is good. During session, and this is why things are kind of crazy for me today, is we have regs that are actually being heard during session. So yesterday, the regulations were heard before the Senate committee, standing committee for health and welfare, and then today they're going before the House standing committee for health and family services. Again, program staff have to be available if there are any questions. The other committee that can pick up a regulation is the Veterans and Military Affairs and Public Protection Committee. They recently picked up a regulation that was changing for youth camps. I know during the legislative session they've picked up some of the bills that would address public health programs because it falls into that public protection. So the legislative process is very interesting right now. Like I said, there's a lot going on down at the Capitol, and this isn't a budget session. Budget session will be next year, so I suspect that it would be even crazier next year. The link that I have here is the link to the main homepage for the state legislature. This link, you can look at their calendars, you can see bills that are filed, you can get link to current statutes, current regulations. And then I thought this was kind of fun. This is a long-standing graphic that shows how a bill becomes a law, and it's fun because it's pretty true. I mean, again, you have a bill that gets introduced, it goes to a committee, and this is how the committee amends it. And then it goes to a second committee, and this is how they amend it. And then this is how it actually gets enacted. This is how it's funded. This is how it's implemented by the state agency. I love this one, is how it's reported to the media and how it's understood by the public. And at the end of the day, this is actually what was needed. There is amendments. Those can completely change a draft bill, depending on what the amendment and who sponsors the amendment and kind of what their agenda is. So just because the legislature isn't in session doesn't mean that there aren't things going on. This statute referenced here, KRS 7103, actually talks about the meeting schedule that goes on outside of the legislative session. That typically, those interim joint committees, that's timeline is between June 1st and December 1st every year. Typically around August is when we'll start to see pre-filed legislation. That can be something that a representative or a senator wants to take forward when the legislator comes back into session. It doesn't always have to go forward. Sometimes pre-filed legislation can be just to appease someone. And I know that sounds really horrible, but that does happen. And pre-filed legislation can also be a placeholder. So it's, someone's got a really great idea. They just haven't fleshed it all out just yet. So they're going to put something there as a placeholder so that they have time to work through it so that when the legislature is in session, it's as good as it can be. There's also cabinet level legislation that's worked on during this time period, things that programs might want to change. For example, the Department for Public Health has had a long-standing statute that requires us to investigate and abate a bird roost that's a nuisance. We don't have staff trained to do that, so we worked with our Legislative Office of Regulatory and Legislative Affairs and to put forward a legislation that would repeal that statute. The other thing that we've done, I worked with Troy Cunningham to draft legislation to clean up the long-term care employee immunization process. So to make it clear who has to be immunized and when that has to happen. So those are just some things that we do outside of session so that when session actually happens, you're not scrambling trying to put together things that you want changed in the law. And again, it does take an act of the General Assembly to change a law. So this legislative session actually convened on January 8th, and those first 4 days were just kind of the organizational days, people deciding what committees they were going to sit on, new senators and representatives who were elected actually getting familiar with their office, going through a little bit of orientation. Then they reconvened, part 2, they reconvened on the 5th of February, and that's kind of what has started this ball rolling. The 8th was the last day for bill request, so you couldn't request anything new after that point. The 15th is the last day for new Senate bills. The 19th is the last day for new House bills. And both the House of Representatives and the senators are hearing during this time, are also hearing what is best termed testimony on legislation. They will call the senator or representative who sponsored the bill to the table. That individual may have cabinet level staff, may have program level staff with them to kind of talk about what they're wanting to change in the bill or why they feel this new bill is necessary. They'll also bring in advocates for the bill, lobbyist groups that would support the changes. And this is also an opportunity for people who oppose the bill to be heard. someone who doesn't feel that the language is strong enough or that they don't like the language can come to the table and talk about why they oppose the bill. The concurrence days happen in March, and so any bill that goes forward, if it goes through the Senate, the House of Representatives also has to vote on it. So those are the concurrence days and vice versa. So anything in the House has to be voted on by the Senate. Both entities can make changes to it. They can amend the legislation. They can actually decide not to hear the legislation and just let it die. That happens quite frequently. If you remember, I said sometimes pre-filed legislation is to appease someone, and there's never any intent to actually take it to a committee for it to be heard. That's what is called letting it die. The governor has veto days, and that's the 14th through the 25th of March. He can sign legislation, he can veto legislation. There is some legislation that can move forward and become law without his signature. That's very rarely that happens. And then after the 25th, so between the 25th and the 29th, the legislature can then come back together and actually look at overriding any vetoes that the governor has made. But they cannot introduce any other legislation at that point. And then on the 29th of March, the session ends. And on their calendar, it actually says the session dies, which I think is kind of morbid. I think end is a better term. So there are some legislative things right now that may be of interest to nurses. The top one, House Bill 296, is a loan repayment program from the Department of Veteran Affairs that would repay for RNs and LPNs that are employed through Veteran Affairs. And it grants the authority to both the Kentucky Department of Veteran Affairs and the Kentucky Higher Education Assistance Authority. It grants them the authority to promulgate administrative regulations outlining how that would, how all of that would work. Most bills that if they're signed by their governor, they go into effect 90 days after signature. So typically if he signs them on his last day, you're looking at somewhere at the end of June. A bill can have a special effective date, and this particular effective date, or this particular House bill, if it gets passed, has a effective date of January 1st, 2020, which allows both of those programs, if it's passed, they have time to draft regulations before the law actually goes into effect. The certified professional midwife, that it was introduced in both the Senate and the House. Now, what that means is that both legislative entities are looking at this. It has to pass through both before it goes to the full assembly. And the bills themselves, the Senate bill and the House bill, they're exactly the same language. You'll see that Senate Bill 84 actually has a Senate committee substitute. So what that means is when it was being heard by the senators, I think it was Senator Alvarado had some different language that he wanted into it. And that substitute didn't actually change the intent of that statute or that legislation going forward. It just basically said, I want to change the committee structure or the council structure that this bill would create. And I looked at it this morning, and there's actually already been 2 amendments that have been filed with that. Again, the amendments changed the scope of, or expanded, let me get the word right, it expanded the list of conditions that a midwife would not be able to provide services for. So basically in the certified professional midwife. Thank you for that clarification. In the legislation, it talks about if it's multi-gravida, if the person is a high risk, then the certified professional midwife could not offer their services. And the amendment that was filed expanded those categories. The sexually transmitted disease expedited partner therapy, this is actually a piece of legislation that the cabinet put forward. It was drafted by DPH staff, and they put it forward. It was introduced in both the Senate and the House, and that allows for it authorizes a physician, an APRN, or a physician's assistant to provide antibiotics, drugs for treatment of chlamydia or gonorrhea infections to the partners of a patient who is diagnosed with that one of those STDs. That is something that we would strongly support because definitely it would help to reduce the prevalence of STDs going forward. It does require those practitioners to adhere to the current CDC practice guidelines for EPT. So, and then just a few little final notes on legislation. Again, filed legislation doesn't have to be the same as pre-filed. There are two types of legislation. There are bills, which would then go on to become laws. They can either be codified or non-codified. Codified contains language that changes a statute. A non-codified law is something that's not intended to be permanent law. Resolutions can be either concurrent, joint, or simple. A concurrent resolution kind of expresses priorities or opinions of the Assembly as a whole. It can be authorized to expand funding, and it can be used to request changes to federal language or the U.S. Constitution. A joint resolution has to be approved by both the Senate and the House, and vice versa. And then a simple resolution those are affairs of the House only to express an opinion or convey a message to LRC. Those are typically to honor someone. For example, there was a resolution to designate February 27th as APRN Day. That's an example of a House resolution. Like I said, the legislation takes effect 90 days after session ends, unless there's a special effective date in a bill. And in order for legislation to pass, when it actually gets to the when it gets down to the floor, so the Senate committees, they meet and they talk about, not every committee looks at every piece of legislation. That would be impossible. So, the Senate Standing Committee for Health and Welfare is looking at things that impact the cabinet. Then they take that to the Senate floor, which is all of the senators looking at it. And again, that's another opportunity for testimony to be provided. That's when it actually goes to a vote. It takes a vote of 40 House or representatives or 16 senators for something to move forward. So that's kind of the majority vote. And then if it's a piece of legislation that generates revenue, it actually takes a 3/5 vote to pass on. So I appreciate your time today. I hope I didn't move too fast for some people. But if you have any questions, feel free to give me a call, email me. I'd be more than happy to give you any additional information that you need. And thank you again for letting me jump line. Thank you, Dr. White.
Thank you, Julie. So I'm going to go to the next speaker. I am going to look in the box and see if we have any questions because we are going to be having an opportunity for questions, especially with Dr. Howard's presentation at 11:30. So I don't see any questions right now. I'm going to move forward and go ahead and let Amanda get started. Amanda Hunt is going to talk to us about our hepatitis A outbreak and give you an update. So I'm excited to hear this. Thank you, Amanda, for being here. And thank you for being patient and letting other people jump in front of you.
Okay. Hello, everybody. This is not going to take very long. I know people are probably a little sick of hearing about hepatitis A. I'm just going to give you a brief update. So as of February the 9th, we have 4,091 cases in Kentucky, and 103 of our counties, so 86% of our Kentucky counties have been affected by this. We have a total of 1,982 hospitalizations for a 48% rate. We do have 40 deaths, and that's 1% of the affected population. The median age is 36 with a range of 1 to 84. And we do have 572 who have been tested and matched the genotype 1B. Just a little note about the deaths. We were holding steady at about 20 or 21 deaths, and we did an end-of-the-year vital stats review and learned of some more hepatitis A-associated deaths that we were unaware of using death certificates. So that's why that number jumped, and we did do a press release about that to make people aware it wasn't a sudden cluster of deaths, so to speak. This is just a little look at our outbreak curve. You can see it's, of course, the February one there is not complete, but you can kind of see it's getting a little better from that jump there back in the fall. This is our county distribution, and all of these maps and pictures are available on the hepatitis A outbreak webpage. This is the incident rate, so you can see Eastern has a higher incidence rate. And this is just a graph of the Jefferson County versus non-Jefferson. Jefferson is the little blue line there, and then the other counties are the orange. Risk factors still remain mainly illicit drug use for 71%, although we do have a little bit of an increase in no outbreak-related risk factors for about 19%. However, whether that's because they don't admit to it or we just don't know, it's probably a little misrepresented, or the possibility of. And just a little FYI, the HAV checklist is available on Google Drive, and that just is something that we created to walk you through what to do if you have cases, or your first case, or whether you've had multiple cases. That's available. Hopefully that will be helpful. We are working on establishing a nurse strike team for vaccination events at jails. We are sending out guidance requesting continued specimen submission to DLS and encouraging vaccination of at-risk population. And DLS is working on the ability to perform sequencing in-house. And from here on out, vital statistics will be reviewed bi-weekly to just confirm those number of reported HIV deaths. Just a few things to remember. For 317 vaccine requests or questions, contact immunizations at the number there. All vaccines, private stock or 317, must be entered into the registry. And it may be helpful to reach out to schools and encourage compliance with vaccination regulations. We have had several students now diagnosed with hepatitis A who were not compliant with their vaccines. You can access guidance documents on Google Drive or the DPH website. Please continue to send specimens for genotyping and request that your providers do that. And once you put the investigation into NEDS, I'm still experiencing a lot of notifications not being created. So they don't get into my queue, so I can't approve those. If you could just make sure your nurses and everyone's aware to just go ahead and create those notifications. Even if you haven't interviewed the case, you can always go back in and edit NEDS. Does anybody have any questions for me?
So I think most of you know, this is Dr. White again, most of you know how to use the chat box, and I'm assuming that it's working because we have gotten some messages. Okay, let's go through these. So any questions right now for Amanda about hepatitis A? I think seeing that orange line go down in that one slide is very exciting, because I think it shows all the hard work that everybody out there has done, the work with the jails, the work with behavioral health, the work with the medicated assisted therapy providers, the methadone providers, all the different entities that y'all have thought of that have really shown us that there are lots of different places we needed to go. This outbreak is like nothing else. If you think of that 4,000 number that we've had in Kentucky, the whole United States in 2016 had 2,000 cases. We've had over 4,000 since November of 17. So I think the fact that that number has gone down is a testament to everybody and their hard work. But it can go up. I mean, it's not going to take just a few cases in the wrong areas for that number to go up. So that's why we can be very pleased the numbers are going down, but don't want to let our foot up on the brake on that. So we want to go ahead and move forward. Okay. Thank you, Amanda. Thank you for letting us jump ahead of you. It doesn't appear so. If you do have questions, though, send those to me. I don't think Amanda's got her.
I do.
You do have your contact information. Is that the next slide?
I think so. Or maybe.
Close that box. Let's see if we can find that. Let's see that.
There it is.
There's the contact information. Okay. So those are all the folks that can give you the information that you need to find out about hepatitis A. So right now, I think someone took my notes that I had laying here. So we're going to go ahead because David is in the room, and we're going to go ahead and get started. I'm going to just take this slide deck off. I'm going to go ahead and just put the welcome slide back up, and we'll let him get started and talk about TRAIN. Did you have slides?
No, I'm good. All right, let's talk about TRAIN 3.0. Back, I guess it's been about 3 years ago, the vendors of TRAIN decided to move TRAIN off of the Microsoft SQL database and move it to an open source database. And this was actually implemented January 1st of 2018. And along with that decision, they said, well, while we're in here changing databases, let's go ahead and just go through every screen of TRAIN, and let's just update and go out on TRAIN and change how things, procedures and processes and so forth. Let's tweak them and bring this into the 21st century. Where this is important to us is the old TRAIN, they're referring to it as classic TRAIN, and that has a URL of ky.train.org. When they changed to the new database, January 1st of 2018, we received a new URL. And that URL is www.train.org/ky. The vendor agreed for a 12-month period to automatically reroute people that went to the old URL, ky.train.org, to the new URL. I don't know when that 12-month period started, and I'm not really sure when that 12-month period stops, but that's kind of important because ky.train.org is everywhere. It's on all of our websites, locally, regionally, at the state. It's all on our marketing materials and so forth, and at some point, somebody's going to type in ky.train.org, and they're going to go to they're going to receive a page now found, the 404 error. So that's the first thing about the transition from classic TRAIN to TRAIN 3.0 is the new URL. The second important thing about this transition is TRAIN 3 is not completely built out yet. I would say we're probably about 85%. The conference package in TRAIN, the assessments, and the evaluations in the course build, and the training plan feature that's really popular are all classic TRAIN versions right now. Over 2019, those will be converted and updated to the new TRAIN 3 format. And I don't have timelines when each of those pieces are going to occur. Training plans have been super popular, especially with programs and local health departments and managing annual courses or required courses of programs. And also CDC has been really interested and likes how that feature works. And so they threw a little money into the pot, and they're actually enhancing all of that training plan feature itself. So I'm kind of excited to see what that looks like when they roll it out. So again, you can use these in Train 3, but when you click on the conference package, it takes you to the old classic Train look. So these pieces are functioning; they're just functioning under the classic Train appearing pages. Also with this, we've made some changes to our nursing CE program. We are aligning processes and procedures a little bit more with KBN and a little bit better with the way that Train 3 operates. And some of these pieces I'll share with you today. First of all, EWD is asking if you're thinking about utilizing EWD and our nursing providership for a online course or for your classroom course. We're asking that you reach out to us about 60 days in advance. There's a lot of temporary folks in place, and there's a lot of steps and procedures to that, and 60 days is even kind of calling it tight for us to get that turned around. Also with your classroom courses, if your classroom course does have a nursing certificate attached to it, another change is those classroom courses, if there's an assessment, the evaluation, the nursing CE certificate, they all expire 30 days after the post last day of that event. They don't just stay open-ended anymore. There's a 30-day window that you need to complete your course, complete your assessments, complete your evaluations, and receive your certificate. After that 30-day period, that will not be available. And another thing I just also mentioned, pre-registration is just required. Post-registration after the event is kind of impossible at this point. Train is going under significant growth and has for at least 3 years now. I think the introduction of the VA hospital system into Train nationwide boosted the number of users in the system to over 1 million. I believe, too, the curriculum that the VA is introducing into Train is growing that catalog. They are beginning to open up some of that curriculum to outside the VA system, and they are really at the cutting edge of what they're doing with online training. I have also been really impressed with CDC these last few years. CDC has really stepped up their game with their online training, and at their CDC Learning Center that you can search for online and at their websites. There's a lot of linkages back to Train courses. They're doing a lot of 101 type series courses, and they just continue to build. And they have done just a real nice job with the curriculum that's growing. So, recap: Classic Train retired, and Train 3.0 came online January 1st, 2018. The URL did change with that new Train 3.0 to www.train.org/KY. The old URL will be going away. This year will continue to be a year of change with Train, and there will be new features, and there'll be old features that will be updated to give the new Train, to reflect the new Train 3.0 look. And our nursing CE process is also changing, reaching out to EWD 60 days in advance of your program. Your face-to-face courses have a 30-day expiration as far as evaluations. You have 30 days to complete your evaluation and get your certificate. Day 31, that will no longer be available to you. And pre-registration is required for all our face-to-face courses. And just continue to search that train database and look for new curriculum that's being added, especially from the VA hospital. You can just search by the VA and find curriculum and CDC. Reach out to us on the training plan feature if you would like to utilize that in your health department. Also, another thing that's gaining popularity across the Commonwealth is the food safety module, and I will work with you on that to get that set up for your health department. Just monthly, I get more and more inquiries about that, where health departments are doing more online training with their restaurant workers and trying to reduce the number of classroom trainings that they're offering in their health department as a cost savings. That is all I have to mention now about training, and I thank you for your time.
Thank you, David. Appreciate those comments. Just so that everybody knows, this is being recorded, and we will be posting the agenda and all the PowerPoints on the nursing office webinar. Just recently, I decided to look at the nursing office's webpage, and I know all of y'all know we've had a changeover in our CHFS webpage, the whole website, and there's such outdated information on that webpage. So just so you know, that is being revived. Deb Colston, for those of you who don't know Deb, is our administrative assistant in the Commissioner's office, and she is learning to be a webmaster. So with Deb's help, we will be able to make this really something very usable for your staff and you to use. And so you will see all these PowerPoints, and I will see if I can get David to put a PowerPoint together too, just so you'll have all that information that he just shared. We are very fortunate to have Dr. Erin Blau here today. She is a, oops, let me start back again at the beginning here. She tried to start this webinar at 9:30 and was standing up here thinking we were recording it, and then we discovered that we were just talking to ourselves. So this is her second time of presenting this, so we owe her a double thanks for her work in this, not only in this area, but also for being a trooper. But I'm going to turn you over to Dr. Blau now, and she's going to have some very interesting information about HIV in Kentucky.
Thank you so much, Dr. White. And do I have till 11:30?
Yes, you do.
Okay, so I'll try to squeeze in both these updates. So as Dr. White mentioned, my name's Erin Blau. I am the Epidemic Intelligence Service Officer, or EIS officer, here at the Kentucky Department for Public Health. EIS is a 2-year applied epidemiology fellowship with CDC, and so I'm here with the Kentucky Department for Public Health for 2 years. I started in August, and in that time frame, I've participated and led on a number of investigations, and so I'll be giving an update on the HIV increase among people who inject drugs in northern Kentucky in the Cincinnati metro area, and then that'll be followed by an update on the current ongoing investigation on vaccine-associated infections in Kentucky, Ohio, and Indiana. Okay, so some of you are likely aware of this, but some of you may not be aware. So just as some background, in 2017, the Kentucky Department for Public Health, where HIV surveillance is housed and where they routinely monitor HIV diagnoses and risk factors, KDPH began to see an increase in HIV diagnoses among people who inject drugs. And so this increase obviously prompted the local health department and the state health department to work together to identify what may be causing it. And of course, looking back at previous cases, it's important to note that northern Kentucky typically sees about 5 or less cases.
Jennifer, we just got your voice over, so could you put your computer on mute, please? Thank you.
Okay, so northern Kentucky typically reports 5 or less cases associated with injection drug use, so an individual disclosing injection drug use as their primary or only risk factor for HIV transmission. And in 2017, there were 18 new HIV diagnoses among people who inject drugs, so a tremendous increase just in a year's time. So here you can see actually the headline for the first press release that northern Kentucky issued, and stating health officials see increase in HIV infection among individuals who inject drugs. So this press release was issued January 9th, 2018, so over a year ago now, and just stating what they're realizing and, giving an update on what response they have organized at the local level. And this is one of the huge strengths at the local level of Northern Kentucky Health Department is their communication with their community and with their partners on how their response was shaping. So, of course, there are a lot of unique challenges with this investigation. It's not, as simple as other investigations. Of course, the nature of HIV infection, but HIV infection among people who inject drugs, a lot of new challenges to consider, and especially in this geographic area. So as you know, Northern Kentucky borders Ohio, and this outbreak did not just occur in Northern Kentucky, it was across the river as well and taking place in the Cincinnati metro area. So this population is not stagnant. They move across the river. They may live on one side and work on the other, work on one side, live on the other. So it's really a shared population here, and of course, the investigation involved both sides. So a lot of challenges when you talk about working across two local jurisdictions, Hamilton County Health Department and Northern Kentucky Health Department, but also two state health departments, so Ohio Department for Health and Kentucky Department for Public Health. Inevitably, there's challenges with data sharing agreements, also timely case follow-up, especially given the burden of cases being found as part of this investigation. This was also a real shift for DIS, or Disease Intervention Specialists. So HIV case follow-up for them has primarily been focused on the population of men who have sex with men. While they do receive cases with people who inject drugs, this investigation really was a changing point for majority of their caseload now was surrounded around people who inject drugs. So this is very important to consider when talking about just the burden on the local jurisdictions to respond and be able to effectively manage contact tracing. So some unique considerations with this population that you might not think of until you work with this population more closely, but people who inject drugs, they have a much higher rate of homelessness, a much higher rate of incarceration. They can be extremely difficult to locate or communicate with, whether because of their housing status, their institutionalization, whether in a jail setting or in an inpatient or outpatient substance use treatment program. And then what we found through this investigation, too, is there's quite a high rate of marginal contacts. So these are individuals with nicknames, or they don't know where their addresses are, or they move around a lot. And so if interviews were completed, the contacts they were given information on were unable to locate, so calling those marginal contacts. And so, of course, all of this carries over in the work and how difficult it can be to, once someone is diagnosed, linking them and maintaining them in HIV treatment, which is crucial to achieve viral suppression. Okay, so here is a shared press release that was issued from Hamilton County and Northern Kentucky. This was issued the 23rd of October of last year, so a little bit more recently. In this press release, both local jurisdictions highlight the increase in cases among people who inject drugs. So from January 2017 to October 2018, Hamilton County saw 89 cases of HIV attributed to injection drug use, and Northern Kentucky saw 45 cases attributed to injection drug use. Very important to highlight that these jurisdictions combined previously saw less than 20 cases a year, so quite a substantial increase. And even despite best efforts at the local level through testing, enhanced interviews, enhanced testing at the local level, and creating opportunities for testing and syringe exchange, these cases were sustained over time. So Hamilton County and Northern Kentucky, with the work of Ohio Department for Health and Kentucky Department for Public Health, partnered together and requested a joint EPI-aid, which is assistance from the CDC. So this press release was issued on October 23rd, and the EPI-aid response started on October 22nd. So I'm going to back up just a moment just to explain what an EPI-aid is, because this might not be a common term you hear. They're not called all that often, or you might not have ever called one or participated on one. So an EPI-aid is a response to an urgent public health issue or emerging issue. This is an EPI-aid response. It's requested at the state level typically. So it can be a local issue, but it comes from the local jurisdiction to the state, and then it's the state epidemiologist that makes a formal request to the CDC. So this is typically technical assistance and typically in the field on-site assistance from CDC subject matter experts, as well as integration with the local staff. These EPI-aid responses are typically rapid, short-term, 1 to 3 weeks. And it's all about assisting partners in making rapid decisions related to this emergent public health issue. For the Northern Kentucky EpiAid response, this took place over a 4-week period, and it was really focused on integrating and analyzing data across the 5-county region. It was also focused on the rapid assessment through key informant interviews. So this was about conducting qualitative interviews with key informant or key stakeholders in the community, including partners in law enforcement and health services, but also interviewing those who inject drugs in the community, whether they're HIV positive or not, to get a better understanding of their HIV risk factors. One of the last things we did as part of this EpiAid response was conduct case interviews or case reviews. So looking back at those who had been diagnosed during this time frame, if there were opportunities for diagnosis earlier and when they were interacting with healthcare services. So the overarching theme of this EpiAid was really to better understand current response and identify additional prevention and control measures. All right, so some of the findings of this EpiAid response, it was very clear through this work in 4 weeks in the field that there was rapid transmission among the people who inject drugs networked in this region. While we assumed that there was some transmission through HIV new infection, we also knew that there was diagnosing of late infection. It also was clear that sharing and reuse of needles and equipment was common among this population in this region and really highlighted a need for increased access or awareness of syringe service programs that are available in that region. We also found a substantial amount of mental health issues and stigma perceived by this population being reported through different qualitative interviews, and so the need for integration of mental health services. And then through case reviews, there was numerous missed opportunities for earlier diagnosis, so meaning when individuals were seeking health care, and especially for injection drug use related visits, so overdoses or abscesses, there were opportunities to test for HIV, but they were not tested and were later diagnosed. So the recommendations from this EpiAid response centered around comprehensive syringe service program delivery, expanding HIV testing to other settings, especially for this population, and that would include jails and emergency departments. Improved care coordination, so not just about linking those to HIV treatment, but also to other supplemental services like housing services, mental health, substance use treatment. And then, of course, this was something that Northern Kentucky and Hamilton County did wonderfully before the EpiAid response was ever even started, but sharing data and integrating their response to this investigation was crucial. And so as part of the EpiAid recommendation, it was just really reinforcing this continued work moving forward. All right, and so here you can see a screenshot of the Northern Kentucky Health Department page where they actually post their health alerts. You can see the news releases that have been issued from Northern Kentucky dating back to the beginning of this response, where they detail what they're doing to respond. They've really been great at communicating all of their work to the public, to their community, and to their partners. And so here you can see those press releases as well as current data that they're reporting on the investigation. And I just wanted to highlight this as a resource for you all to look at, a model for communication at the local level. And of course, to just give credit where credit's due, all of the information I shared today is from the Northern Kentucky Health Department page, so you can access it at any time. And so you might be wondering how this applies to your own work at the local level, and if your area is affected, or what you should be taking away from this. And so I think this is an important time to revisit the vulnerability assessment that was conducted by the CDC just a few years ago. And so, of course, this was on the heels of the Scott County, Indiana HIV outbreak, where we're all aware there's a very large increase in HIV diagnosis and transmission among people who inject drugs. And so after that outbreak, CDC conducted this vulnerability assessment to identify where else in the country where other counties may be at risk for a similar outbreak, because this was devastating to the community in Indiana. And so through that assessment, they identified 220 counties that were at risk. And of those 220 counties, we held quite a few in Kentucky, I believe 54 total. And so you can see that here on the map. And so this is just a reminder to see, injection drug use is not only increasing across the country, but it's certainly increasing across the state of Kentucky. And it's something that we need to be constantly enhancing our prevention efforts, especially related to HIV and hepatitis C prevention. So here you can also see the distribution of syringe exchanges throughout the state, as well as those who may have approval but not yet operational programs. And so this is a great time to highlight Monica Ridgway. She's our harm reduction coordinator here at the State Health Department, and she is a wealth of knowledge and information when it comes to harm reduction, as far as, securing funding for your program, bolstering your program with other services and different programs within it, and just different prevention messaging. And so I just wanted to provide this if you weren't already aware of it. There's a lot of information located here at the state that she'd be happy to share if any of you have questions. So her number and her email are here, and this will be posted afterwards. Okay, so I've still got a little bit of time, so I'm going to go ahead and get started on the update for vaccine adverse event investigation. So this investigation is ongoing. You may have heard of it in the news recently, just with our press release we issued, and you might have seen the provider Hans that we sent across statewide multiple times in the last few months. So there might be a little bit of knowledge there, but I think I wanted to take this time to really highlight what we know and what's important for you all to know as local public health nurses, and how you can respond and be a part of this and really learn from what we're learning as part of this investigation. Okay, so just to get everyone on the same page, because I think there's a differing knowledge of the situation, on December 4th, Kentucky Department for Public Health was notified by a Clark County provider of several cases of abscess-like reactions following vaccination at their employer's site. That there was one company identified as providing vaccines at these different employer sites. So as a precaution, the company was asked to cease all vaccination, and the remaining vaccine supply that this company had was then collected by the local health department, Montgomery County Health Department. These reactions include increased redness or severe redness, pain and tenderness at the site of injection, swelling at the site of injection, and then typically involve development of a hard nodule or lump at the injection site. There's also some individuals, or quite a few individuals, that may also experience opening of that abscess, opening of that nodule site, and formation of an abscess and drainage at different times after symptoms have developed. So while this company did stop administering immunizations, it's still possible that individuals previously vaccinated by this company could develop infection. In fact, symptoms may start as quickly as same day or next day, but may not develop more than 12 weeks after. In fact, we've had some individuals with symptom onset 4 months or more after their vaccination date. So very important from a local health department standpoint to just be aware that reactions may be delayed. And so medical care is advised, since these infections will likely not go away on their own. Okay, so on December 7th, at this time, we believe vaccinations were limited to nearby businesses in the Mount Sterling area. So we sent out a regional health alert notice, or HON, to providers in Montgomery and surrounding counties. We proceeded to contact the named businesses and provide letters to their vaccinated employees. I also want, this is about the time where we realized that some lab results were coming back from those who experienced reactions, and these lab results were becoming positive for Mycobacterium fortuitum. So for those of you not familiar with that pathogen, I know I wasn't until this investigation, Mycobacterium fortuitum, it's a mouthful, it's a non-tuberculous mycobacterium. So it's very slow growing, it's typically found in water, and it's not routinely tested for by healthcare providers as part of a typical culture that we came to learn of at the beginning of this investigation. So because we were aware that this was a pathogen that had been identified in at least one patient, we proceeded to move forward with contacting companies and employees. Now, just to backtrack to the previous notation, just to indicate vaccinations took place from September 11th to November 1st, and that's what was reported at this time. So then we proceeded to contact companies and employees and interview them. Because we are aware of the mycobacterium, we also began creating a new provider health alert notice so that individuals were aware of the necessary, or providers were aware of the necessary testing to detect Mycobacterium fortuitum. It was also at this time, through additional interviews with the companies and the employees, that we discovered that some of the involved companies had locations in other parts of Kentucky, as well as in Indiana and Ohio. So at this time, we sent out a health alert notice, not just regionally, but across the state, as well as notifying Ohio and Indiana's health departments. And so we continued to interview companies and employees, and on January 18th, we sent out an additional HON statewide again to remind providers about appropriate testing and reporting, and of course that this issue was still ongoing. All right, so by February 1st, there was concern that additional businesses or companies may have received vaccinations from this one provider, and a press release was issued to ensure that individuals were made aware of the need to revaccinate and seek medical treatment if they received a vaccine from this provider at a workplace event. So here we are, the press release. So this is just a quick screenshot of the press release that was issued on February 1st. I just want to highlight some key components to the press release and explain why we did the press release and why we included information that we did. You're free to take a look at this if you haven't already seen it. So in this press release, we do include the company and provider's name, because at this time, while we were aware of the company name, when we were interviewing different companies that had hired this company, they weren't familiar necessarily with that name and were only familiar with the physician's name. And so it was necessary at that point to identify those who received vaccines from this particular contract agreement that was identified. We also included in this press release a timeline of events. So from our interviews, it was clear that vaccination started around September 11th, but we wanted to ensure that we captured anyone who might have received vaccines. So we stated from September 1st on, anyone who received the vaccine from this provider should seek additional revaccination. So that's the next 2 points, is we really wanted to get the message across that there's a need of medical care for anyone who is experiencing a reaction, because these reactions will not resolve on their own given the pathogen that's likely involved. And then there's a need for revaccination. So through our company interviews and through our on-site visits to the clinic where vaccine was prepared and stored, it was clear that the vaccine may not be effective with the way it was handled and stored and transported to off-site events. And so as the Kentucky Department for Public Health, we wanted to get the message across that anyone, regardless of experiencing a reaction or not, should receive revaccination if they their initial vaccines were through this company. And then, of course, to remind any businesses, individuals, local health departments to continue to report cases to the health department. So some key takeaways from this investigation, what I'd like you all to come away with this is, if you have individuals who are concerned about experiencing a reaction following a vaccine, please advise those patients to seek appropriate medical care. Please continue to report those reactions to the Kentucky Department for Public Health. Of course, complete a VAERS report form, so that's the Vaccine Adverse Event Reporting System, making sure reports completed, and not just you, but this can be completed by the healthcare provider who's assessing the reaction, the healthcare provider who provided the vaccine, or the individual themselves who is experiencing the reaction. Revaccination is recommended, so that's very important to get across to anyone who's vaccinated as part of this company's employer-based sites. And then this investigation, again, is only limited to vaccines administered by this one company and provider. There's not an issue with the vaccine supply. We've investigated lot numbers, different vaccines. These reactions are occurring across separate vaccine types. And so it's just very important that the message is clear, is that it's only related to this one specific provider and at workplace settings. So we're learning a lot through this investigation, and we want to be able to learn from this process and give you the information and tools you may need to prevent this from happening in the future. So, of course, in the next few months, we'll have a lot more to provide, but at this time, we just want to take a moment to remind all of you as champions in immunization, as public health nurses, just, remind on the checklist and the necessary training and guidelines related to vaccine handling and storage. So our immunization program here has provided 4 resources for you all, just as a refresher. They include the checklist for safe vaccine storage and handling, as well as a skills checklist for vaccine administration. Something we learned as part of this investigation is that there are not limitations on the training that one must receive prior to vaccine administration. So it's always good to do a skills checklist to make sure that your staff are comfortable and appropriately trained to administer vaccines. These resources also include tools for assisting in satellite, temporary, and off-site vaccination clinics, and then vaccine storage and handling 2 clinics, the most recent one for 2019. So these are all great for you all to use, but then also champion and spread this to other community providers and those immunizing in your county, just getting that message across so vaccine is stored and handled appropriately. And so thank you so much for listening to these updates. I just wanted to provide my contact information as well as Andrea Flincham. She's our Healthcare Associated Infection Prevention Program Manager. Both of us have been actively working on this investigation, and just want to provide our email and our phone number if you have any questions moving forward and want to get in touch with us related to this investigation.
Super, thank you, Erin. I've been in part of this from the very beginning, and this was just a really nice assessment, and I really do appreciate it. As I said before, all of these slides will be posted on the nursing website. And so what we're going to do now is you have an extra added speaker at no extra cost. We have Ram is our epidemiologist in the Women's Health Program, and while he is talking to you, I'm going to be loading up Dr. Howard's slides. So, Ram, you're not going to be seen by them. They're just going to hear your voice. So okay. If you'll go ahead and get started.
Yes, I'll be very quick. Thank you, Dr. White, for the time. Just wanted to share with you all that last week we have shared with you a new CPT code list, which is a KWCSP approved CPT code list. Which is a version 9.0. This CPT code list is effective from January 1st, 2019. Compared to previous CPT code list, the rates are higher, and we have got new CPT codes added to this list. So if you have not received it, just please send me an email. I will be very glad to get you the new and latest update on the CPT code list. And there's an email that talks about the contracts also. That's about the CPT code list, and also you all know that WH58 form, which is the previous ACH 58 form. You all have been using it. I got a lot of questions, and on the WH58 form, I request for your feedback, and just please let me know if you have still difficulty in accessing the data screen from the CDP. I know there are a few technical issues, and CDP has been working on that, but please let me know if the screen does not pop up when you enter the patient eligible information in the registration screen. So two things. One is, again, please let me know if you have any questions on the WH58 form and the screen is not popping up, and if you are unable to, if the system is not holding the data. A couple of them have requested and shared with me that the data is not holding in the system. So if you are encountering those kind of issues, please send me an email. I think that's all I have, Dr. White.
Okay, and we'll have Ram put a slide together for this, because we will be posting all of our slide decks on the nursing office website. So if you can put kind of that concisely in there, okay, then we'll add that. We'll add you to the agenda. Okay. And we'll put the agenda and all of the slide decks on the nursing office website. So thank you for sharing. I know that it's important for the program to get that feedback, that's very critical. Okay, well, we are, again, thankful that we were able to get on GoToWebinar, and we've gotten that all going, and I think this has worked. We do want to make sure that for those of you that don't know about the chat box, because you can chat questions in, because with our next speaker, we are anticipating a lot of questions. I am very pleased to introduce to you Dr. Jeffrey Howard, who is our Commissioner for the Department of Public Health. I won't do a long, lengthy introduction, because I think the most important thing is you need to be aware that we are undergoing a public health transformation, and I would like Dr. Howard to come up and get started and talk into the microphone, although they can't see you. All right, good. I'm afraid to find a way that we can make your face seen, because I'm afraid that if I mash a button, something will disappear. So we'll go ahead and get started.
All right. Well, thank you, everyone, and thanks for joining this ITV. Connie, do we have a running number of how many people are watching it?
Well, we know that we have 26 sites, and so there are several people at each site.
All right, fantastic. Well, folks, we're going to go through. Kelly, where's this plugged in at?
Left it here.
All right. No, it's not working. All right, there we go. It wasn't clicked. All right. So we're going to go through a few things with public health transformation and some of the things you can expect at your local health department level as it relates to that. and I'll go through some of this. But really what we're trying to do is simplify, focus, and prioritize our public health system, because we believe that we've been, this is based on feedback from the local levels, we've been an inch deep and a mile wide for too long. And so basically I want to tell you a little bit through these disclosures about what I think about public health. Now, number one is I believe every Kentuckian should have access to a high-quality public health product, no matter where they live, whether that's Pikeville or Paducah. I believe that we all got to be accountable. That includes the locals, but it also includes us here at the state. I'm committed to using evidence-based and best practice public health approaches, and I emphasize public health because there, in my mind, is a difference often between a medical approach to solving a disease and a public health approach. And so as we are a public health organization, our focus should be on the public health approaches. When I thought about this transformation process, and as I'm going to describe it to you in a bit, it was really not a DPH, Department of Public Health, or a state versus local approach, but it was really how can we as a system organize ourselves to be the best we can possibly be. The other thing I wanted to address here is that I want you guys to know that I'm committed to our shared governance structure. Early on when we started talking about restructuring our public health system, people thought that meant that we were going to try to do away with shared governance, we were going to take autonomy away from the local health department, and that's just not the case. And then lastly, I believe that both our public health problems and our solutions are locally, and we need to look to locals to lead the public health system. Our goals for designing this transformation was, one, to relieve the financial issues that are facing this, and I'll describe that in a little more detail, but you guys should be acutely aware of the financial, severity of our financial system. We wanted to introduce a more modern, simplified, and focused public health model with clearly defined priorities that is based on Public Health 3.0 principles. We wanted to create the accountability at all levels of the system that we discussed earlier. We want to improve our leadership capacity at the state and local levels and every level in between. We want to prevent duplication, reduce waste and red tape internally and externally. And we want to support those data-driven, evidence-based, best practice public health approaches that we discussed earlier. And so really we had several challenges we had to address, and I'm going to talk about 4 of them here. But the most important that you need to know about is the financial problems we face. Our current budget projections show approximately $40 million deficit in the next fiscal year. That's directly related to our pension cost increases. Because of that deficit, up to 42 of our local health departments face financial default in FY20. That is, 42 health departments are on the clock July 1 of this year and at risk of closing within 12 months. And here I show those counties. In red are the 42 counties that are at risk. Yellow shows counties that are at risk within 24 months. What you should take away from this is up to, or more than 64 counties, so more than half the state's 120 health departments could close their doors in 2 years if we don't act. That tells you how severe the situation was and why we felt that we needed to overhaul the public health structure in a rather serious and quick fashion. So how do we get in this position where up to 42 of our health departments may close their doors in 1 year? And the first is the Affordable Care Act. This is not a value judgment on the Affordable Care Act, whether it's good or bad. It's just to say it changed the makeup of public health across this country and state. And most states began to transition to the Public Health 3.0 and preventative care models after the implementation of the Affordable Care Act. Some of your local health departments have done that, but as a whole, we have not transitioned our system. And then probably most importantly and most pertinent is Kentucky's pension crisis. As you guys know, we are one of 2 or 3 states in the country that have major pension issues, and we are significantly underwater, and this administration has made it a priority to salvage the pensions moving forward. As a result, that created the $40 million deficit we're discussing. But despite these financial challenges, we can't forget we're still 45th out of 50 states, and we dropped 3 spots in the last year, according to America's Health Rankings. We've only been above 40th in the top 40 states once since 1990, so we haven't achieved the outcomes we have. And I'm a big believer that systems and how a system is designed either sets you up for success or failure. Now, that's not to say that anyone designed this system that isn't working, but the bottom line is it isn't working for us to achieve the outcomes we want. So it's time to try something different. And so this is a quote that exemplifies that by folks from the Harvard School of Public Health and the Institute for Healthcare Improvement, Earl Conway and Paul Batalden. And this quote is pretty famous in systems improvement literature, and it essentially is, every system is perfectly designed to achieve exactly the results it gets. So the challenge for us is how can we design a system that allows us to achieve the results we want, a healthier Kentucky for all of our citizens. And so that brings me to the second challenge, and what I think is truly the challenge we have to address as part of public health transformation. And that's that our current programmatic services at the local level are not really reflective of community public health needs. That's not to say that everything that you're doing isn't important. That's not what I'm saying at all. It is important. Or that it isn't valuable, because it is valuable. But with limited resources, we need to be able to focus on our highest priorities, and we haven't been able to do that with our current funding structure. Largely, this is driven by the way the federal government funds public health. As you guys know, we get funding from the federal government in a rather programmatic fashion, meaning we get a grant from the CDC or HRSA or some variation thereof to do a specific program, i.e. breast cancer or colon cancer. And so we'll get money just to do those programs, and we try to distribute that money out evenly to health departments across the state. Oftentimes, it isn't enough money to cover the cost of the program, so you're also putting local dollars into those programs. What that does is forces you to offer programs that may or may not be your local priorities. So we need to set up a system that allows you to access and funding and implement the programs you think are most important for your communities, rather than pushing them down to you in a fashion that may not allow you to differentiate your service offerings in a manner that it needs to. Moreover, we need to reduce some of the bureaucratic layering that has occurred over time. It's just a natural progression of programs and systems over time to add more and more layers, and we need to strip some of that down so that we can run as efficiently as possible. A couple other challenges that I'll move through rather quickly are, one, legislative issues. The current public health law is voluminous, it's disparate, and we really need to simplify it and make it work for us in a way that it hasn't in the past. And then fourth is our shared governance structure. Now, I told you earlier that I'm committed to shared governance, and I remain committed to shared governance, but it is a challenge when you're trying to do a large change process. I don't intend to change shared governance at all, but I just want to make everyone aware that we have to work together if we're going to get this done, and we're going to salvage the health departments that are at risk in the next 2 years. So with that said, let's talk about what the transformation is going to look like. The first thing I did was sit down with a group of health department directors, my staff here, and decide what would be the most important offerings that we have in public health. That is, what should every Kentucky citizen have access to from public health across the state, no matter where they live? And we define that as core public health. And it consists of 4 things. First is a foundational public health package that includes 5 focus areas. These are 1, population health, 2, enforcement of regulation, 3, our emergency preparedness and response, 4, communicable disease control, and 5, administrative and organizational infrastructure. Community, and then the other thing that I've added to this that is somewhat different is community health assessments. The second program that we have part of CORE is WIC, our Women's, Infants, and Children's Food Program, HANDS, which I think is probably the most important program in all of public health, and then fourth, our harm reduction, substance abuse, syringe service programs. That rounds out what we think are CORE. Again, in my mind, that's available to every Kentucky citizen, Pikeville to Paducah, Louisville to Harlan. No matter where you live, you're going to have access to these programs. These are the only things in the future that are due or assured. In the past, we've required health departments to sign the master agreement that listed all the programs that we offer and have funding for from the department. And we essentially require that they do or assure all those programs. In the future, that won't be the case. Health departments will be able to pick from a menu of services. We'll distribute our funds as we can, but mostly the health department offerings will be based on local priorities outside of CORE. I'm okay with health departments finding other community partners to offer these services. If your health department has a partner in the community who wants to offer WIC or HANDS on their behalf, I'm okay with that. In fact, I'm even okay with them stepping out of the middle and us doing the administration and the monitoring from the state level. And Louisville does this already. So this is something we can do, and I'm open to if it reduces some burden on the health department. But I want us to agree that these are the most important priorities we have in our system, and should that outside partner go away, that the health department's ready to step back up. Do you get questions as we go, Connie, or?
You can get questions in the chat box.
Okay. Okay,
yet.
good. If you have questions, feel free to ask them, or we can take them all at the end either way. So everything else in public health in the future will be what is called local public health priorities. So every health department will offer the core package, and everything else that you do beyond core will be based on priorities that are defined locally. I'll talk a little bit about what that looks like. But first, these are some snippets from some websites of departments of public health across the country. And everybody's talking about how do we make healthier communities? How do we focus at the community level? And I really think this is us jumping all in on community health and really making community priorities our priorities. And so I think we can be a leader in the nation in terms of doing that. And this is, in my mind, what I would call an emergent system, a system where our priorities, our direction emerge from the bottom up rather than being directed from the top down. So we're really putting the power in the hands of the local health departments to guide our public health system, which is a new and novel way to do it. You guys have seen this foundational package before. It would just look a little different. And this was an excerpt from what is known as the People paper that was written by several health department directors 4 or 5 years ago. This does not include all the services that will be in foundational, but it just shows you this is no surprise in health departments and their directors you've seen this before. Dr. Julia Kosich from the University of Kentucky is currently working on our legislative crosswalk that will further define this work. The only thing different in foundational here is the requirement for a community health assessment. Let me take a moment to talk about population health here, because I know population health has lots of definitions, lots of connotations. What I'm really asking for in this category or this focus area of foundational health is 3 things. 1, health education, which is here population level health education, not individual patient health education like DSME, but rather population level programs. Think of CDC High Five. The other is partnership development, and then 3rd is policy and advocacy work, which is a cornerstone of Public Health 3.0 models. The challenge I had, though, is if I'm going to put the onus on health departments, I'm going to give them, you as health departments, the responsibility to define local health priorities, which is going to be the majority of what we do in public health in Kentucky, and it's going to inform the state's direction. How do I allow you to have how do I make sure you have the autonomy to do that, but at the same time, making sure that the work that's produced is accountable? And so we come up with this algorithm. And this requires the introduction of a new public health advisory board or accountability board. We haven't set on a name yet, but essentially a local health assessment will be done. And I don't put community health assessment here for a specific reason, because it may be a community health assessment or it may be some variation thereof. Okay? Because community health assessments via the typical MAP process are occurring every 3 years or so. This process, things change over the course of 3 years. So there are ways that we can get around this through assessing the local health needs that are not formally a community health assessment. But essentially, you'll do some sort of assessment of your community, and from there, you'll identify your local public health priorities. And then after that, I want you to do an environmental scan. Hopefully, your environmental scan is part of your local health assessment, but I separate it here to bring attention to it and what I want to accomplish. So let's say you identify diabetes as a local health priority. I would ask you then to scan the environment, look in your community and say, who's doing diabetes work? Is there a large hospital system? Is there an FQHC, a rural health clinic, a large physician practice, etc.? Who's doing this work? And ask yourself this question. Is there someone already meeting the need we have identified, or could someone meet that need? If the answer to the question is yes, then we just need to support and complement those folks. If the answer is no, they're either not doing it to our standard or they're not doing it at all, then we may need to create a new program. And so what I would then ask you to do as a health department is justify the priority you've come up with based on data. You got data to support the need. If diabetes is your chosen public health priority, you got data to show that is your priority. And then develop a program that will address that problem. So if it's diabetes, it may be DSME, it may be DPP. Make sure that's a good evidence-based program. And submit that to a board, the Public Health Advisory Board. Let me introduce you to what we have as a preliminary structure for this board. We have 5 members, the CADA president, the CALVO president, the KPHA president, a university representative, and the Commissioner of Public Health. This is where we're really going to bring accountability and transparency into our system. We're going to make sure that those public health priorities check the boxes to meet the needs, but also it lets us to know what everyone's doing in public health across the state. And it's not, when I say us, I'm not talking about the Department of Public Health. I'm talking about us as a public health system. both state and locals, to have transparency so that you guys know what other counties are doing in public health and how they're addressing certain needs. Say, for example, you start a suicide prevention program. Well, it'd be nice for you to know that there's 5 other counties doing suicide prevention, and 3 of them are doing the same program as you, so that you can connect for shared economies of scale, sharing services, resources, etc. So okay. So there's some. This is where our accountability and oversight will come in the system. The board really has 2 functions. First is it's going to create, review, and disseminate evidence-based packages for common public health programs or problems in Kentucky. So what I mean by that, let's say you identify diabetes as a program. We will have available to you a package of programs that are evidence-based public health approaches addressing diabetes. So as a result, you guys will be. Somebody's mic or mic isn't muted, and I can hear your feedback. If you don't mind, just mute your mic, please.
If you don't know, don't worry about a thing.
Hey, you guys, somebody's talking about a shot record and their mic isn't muted. If you don't mind, just mute your mic, please.
No, they didn't.
All right, I'm just going to keep going. So we'll create and review and disseminate evidence-based packages. And so, for example, if you've identified diabetes as a program, you will be able to go to a package of resources and say, here are 5 evidence-based public health approaches to addressing diabetes. And we'll do that for public health issues in Kentucky. What that will allow you guys to do is to be able to create economies of scale. So if we have our health departments doing 5 programs for diabetes or suicide prevention, or pick whatever priority you want, instead of 20, then that allows us to share across our jurisdictions, create those economies of scale that we have to in order to find the efficiencies we need to fund public health into the future. Again, now let me make an emphasis here. This is not to hold your feet to the fire to say your health department can only do one of these 5 programs. Not going to do that at all. We just want to make sure that it's available and that we can help encourage evidence-based best practices and encourage those economies of scale that we think are so vitally important. And then lastly is, we talked about economies of scale. Let me show you the checklist that this board will go through. So when a priority and or the program are submitted to this board, all they're going to do is check 5 boxes. They're not going to make a value judgment on whether your community health assessment is good. If the need is legitimate, they're not going to do that. They're just going to check 5 boxes, and they are, first, is the need that you've identified, the public health priority you have identified, is it data driven? So again, you've identified diabetes as a public health priority. You got data to show that that's a problem in your community. Next is the program or solution that you've come up with to address that need, is it evidence-based or best practice? Again, this is all common sense approaches. Third, you got money to pay for it. That money may come from the state, it may come from local tax dollars, it may come from the federal government, but you got a way to pay for it. Fourth, you got a performance management and quality improvement plan. We should all be doing that anyhow. And then lastly, something a little new is, you got an exit strategy. That's not to say you're going to stop the program by some date, but just thinking about what does it look like if our community doesn't need us to do this program anymore, so that we're not starting programs and continue them in perpetuity for no reason. So that's the 5 priority review. The board is not a state board, it's not a public health policy board, and it's not associated with funding allocations at all. They're essentially going to do 2 things. 1, review and disseminate those evidence-based packages we talked about earlier, and do the checklist. That is it. All right, so I'm going to go briefly over some of the funding here. I just want you guys to understand a little bit about the numbers we have today. And can they see my mouse, Dr. White?
Yes.
Okay. So if you look here, our core package, that was everything in the core box. So foundational public health, WIC, HANS, and our harm reduction package is going to cost us roughly $184 million. We know today we have about $173 million in revenue that will cover those expenses, leaving us with a deficit of about 11.2. What is not talked about here is we've recently confirmed with Medicaid that we're going to be able to get HANS multi-gravida reimbursed, which means we're going to make up a huge amount of cost through HANS, which will decrease this to $11 million. Moreover, there are locally applied environmental fees that will help supplement some of these programs. Also, we're raising the fees for some of our environmental services, which will also subvert this program or subvert this cost. So I expect that $11 million to either be very, very small or non-existent, okay? Also, I want to draw attention to our bottom line. So real quick, this is total funding for Kentucky's public health system. And I want you guys to be aware of this and to get an idea. The reason I'm fairly confident we can come up with whatever deficit exists beyond that $11 million, which I think is going to shrink down to $2 or $3 million, is that the Department for Public Health, you see here, has a budget, an annual budget of $379.6 million. That's our revenues. The local revenues every year are $181.5 million. That means our total public health system has $561 million in it. And so if we can't come up with a few million to fill whatever patches are in core out of the remaining out of that over $500 million, we've got a big problem in the way we put our money where it needs to be. So just going to review some key points. Our strategy here is to simplify, focus, and prioritize. We're waiting on the T-shirts to be made for that, so you guys may get one soon. That's a joke. It's really an emergent system, not a directed system. We really have a serious problem, and this is not just us coming up with some grand idea to try to restructure public health just because we had a whim. We have 42 health departments facing default within the next 12 months if we don't act. Okay, so that's how big of a problem we have. We know that the Department of Public Health's model will have to change, and we're committed to doing that. And I'm going to tell you guys, we have overwhelming support from staff in the department to get that done. The truth is, local health departments will be doing less than you're doing today. Okay, I can't make that more clear. We are going to have to cut some of the programs that we're doing today. There is no way to come up with a $40 million cost with no new revenues unless we do that. Let me take a pause here and say I am sympathetic and empathetic to the situation our local health department's been put in. You guys at the local level did not set your retirement reimbursement rates. You didn't make the decisions for years underfund the retirement and now leave us with this giant cost. That's not your fault, and it's not my fault. I can't control that. And it's someone here at the Department of Public Health's fault, but it's a situation we've been left in, and all we can do is respond to what's available to us. And so we have to realize we're going to have to cut down some of that funding and or cut down some of our programmatic offerings, and that's just a reality. We can't be afraid to be innovative as part of all this. We can't leave any stone unturned that may bring us new efficiencies and allow us to be more effective in delivering the services we are able to deliver. We have to distribute our accountability more evenly. And we have a plan that's budget neutral here that I think can honestly fund our system into the future and ensure that Kentuckians still have access to public health. The Department of Public Health is going to have to find a lot of new partners because as health departments start moving out of programs, and we hear from a lot of health departments who are already switching out of a lot of our women's health type programs. And so we're looking for new partners in your communities to help us fund them. We want to keep those federal dollars in Kentucky. So though some jobs may go away from local health departments, they'll probably still be available in the community just through a different agency. All right. I still got time to, I'm still good? I want to address home health, especially with this group, because I think some of you probably will be home health workers. And there's been a lot of rumors out there that I'm trying to shut down home health, et cetera. That is not the case at all. Home health is not part of the core public health package, but it can be a local public health priority. It just needs to go through the same process as everything else. I will say that home health is a concern for many health departments and directors because of its cost. My position is we just have to make home health budget neutral. That's all. It needs to be self-supporting. And that's been the position, I think, of this department for a long time, and we made that statement. And so we need to make sure that our home health agencies are budget neutral, that they are self-supporting. That is all. And that's the priority, and we're intent on helping health departments do that. If your health department is one that's struggling to balance the budget with home health, we're more than willing to work with you and see if there's solutions that we can reach to help you guys, including billing solutions, productivity, etc. But there will be some health departments, I think, that will probably want to move out of home health. I'm not driving them to do that. That's going to be a decision made by the director and the Board of Health. But again, I'm intent on working with any of our health departments who want to continue home health and supporting them in any way I can. But I want to be clear, I am not going to sacrifice a health department for a home health agency. And I bring that up because there's health departments in this state. There's one in particular right now who I'm in communication with the director, whose home health agency lost $691,000 last year. The health department has a total budget of $2.5 million, and they lost over nearly a quarter or almost a quarter of that, or a little more than a quarter of that, through home health alone. And so we can't continue to do that. And I'm not willing to let that health department shut its doors just to maintain a home health agency. So we got some serious concerns there. We're going to continue working with health departments. At the bottom line is, if you're in a health department that has a home health agency and you work for that agency, be in communication with your director. Make sure you're understanding what's going on. If there's significant budget concerns around home health, then have that conversation with your director and let's talk about how we can fix it. If it can be fixed, great. If it can't be, we'll work through that too. But no, I support our home health agencies. I do think that we do a lot of good for some very needy patients through home health and Medicaid, especially the Medicaid population. Anything else I should add on that, Dr. White? Okay. So a couple updates, and then I'll try to pause and take questions. We do have some legislation popping up that's going to offer health departments a reprieve for 1 year, which will give us a year to get this done, so that those 42 counties will not fail or not on the clock July 1. There's no guarantee that any of this legislation passes, but we have House Bill 308, House Bill 358. And there's a new bill out now that I don't remember the number, but it's another House bill from Representative Rudy from Western Kentucky that also has a pension reprieve for 1 year for health departments. I expect there'll be a Senate alternative soon that pops up. If you guys have any sway with your legislators, please advocate on behalf of a reprieve. We desperately need all the voices we can supporting that.
From your home email, not from your work.
Yeah, from your home email. Yeah. And if you have access, have a meeting with them and discuss the importance of health departments. I found that many legislators didn't know that health departments were quasi-state government. They don't understand often don't understand our shared governance structure. So there's a lot of those problems that we need to discuss. The Department for Public Health is making significant changes now. We have about 10 ongoing projects that are trying to help and make sure that we're positioning you guys and the Department for Public Health as best we can into this challenge. The CDC is working very closely with us and have been very supportive. And we expect to have them on site in the coming months. The advisory committee, which is a committee of health department directors, so your bosses who work with me, about 10 of them come down and are part of a commissioner's advisory committee, and they're working on various work products. I just want to list them here so that I want you guys to know that we're doing trying to make a lot of changes and a lot of important changes, but I'm not trying to drive that from the top down. I'm really letting you guys, health departments, through your directors, drive these changes. So this will give you an example, but Scott Lockhart is working on a revamp of our HANDS program. Randy Gooch is working on a revamp of WIC. Matt Rhodes and Dr. Crystal Miller are trying to revamp our environmental services. Dr. Angie Carmen and Dennis Chaney are working on administrative community health assessment and accreditation. Allison Adams and Dr. Heiss are working on local boards of health issues. Sean Crabtree and Dr. Craig Humbauer are working on preparedness. Dr. Sarah Moria and Andrea Riff are working on our clinical service offerings. So just to show you, this is really coming from the local level. We're not trying to drive this from the state level. Regarding community health assessments, we're really trying to support them, and we're repurposing a large amount of funding in our public health block grant to provide technical assistance to you guys for your community health assessments. Here's essentially an early staffing model, what that's going to look like, but essentially we're going to have a couple staffs at the state level that are dedicated to providing technical assistance, as well as regional staff that are available who work in your health departments that will be available to assist with community health assessments, as well as repurposing some of the time of our regional epidemiologists to support data for your community health assessments, because I know gathering data is a concern. We are going to be piloting this early process at Three Rivers Health District as they go through an update of their community health assessment. And I think it's Montgomery. Is it Montgomery who wants to do a single county pilot as well? So we're going to have two pilots working very soon. So talking about the timeline for this transformation, we are currently in the planning and preparation process. We're working with your directors and your boards of health on what this is going to look like and what it means for your health department. There's a lot of details to fill in. We haven't finalized budgets. We were fairly comfortable with the bottom line numbers, but we got a lot of details to fill in terms of individual budget requirements, what it looks like for a given health department. There's going to be some hiccups along the way, so we got a lot of work still to do. What I'm presenting to you today is not a finalized plan. It's a plan in process. I'm trying to work with your directors to make sure that we have the best opportunity for success in the future. We're going to have an introduction of some legislative work in 2020, and we plan to take this to the legislature in January 2020. But for our statewide implementation, we'll officially start after the legislative session of 2020, assuming this passes. But I adopt this line back because a lot of our health departments are already making some of these changes. And so if your health department is one that are making these transitions, I encourage you to communicate often with us about it so that we can work together to overcome some of the obstacles that may come around. And I show this every time I present these transformation slides, but this has been an issue for a long time. And this slide is a presentation from Dr. Rice Leach in 1999. And it's titled Mandated Service of Local Health Departments. And very similar model to what we're doing here and what we're proposing. So this is nothing new, been around 20 plus years. Here's the local public health stabilization plan or brainstorming from 2011. Here's Dr. Davis in 2012. And the first bullet, if you can see it, is local health department sustainability issues. So this has been going on a long time. I think what we're proposing is a very simplified model and approach to public health. I think it is really an emergent system that puts the power in the hands of our locals where I think it should be. And it's gonna take some changes. And it's gonna take some changes at a time that are a little scary, but any change process is. And I think as long as we work together, we're open and transparent, we can overcome that. So I will take any questions if there are any out there. If not, thank you for your time and attention.
Okay, so we have our chat box up, and we're able to take comments or questions from Dr. Howard. And I hear people out there, so I know you're there, but you should be able to go into the chat box, enter your message here. Let me see if I can.
There's something.
Okay. Will Medicaid payment for HANS multigravid begin within the next fiscal year?
I don't know the answer to that question yet. So what I've been told by Commissioner Steckel is that she's going to make it an absolute priority, and I've sort of asked Dr. White and Andy, surprise, and Andy Waters from HANS to run that. But we've been assured by her she'll make it an absolute priority. I want you to remember that we have if we get the reprieve that we're advocating strongly for, that it'll give us another year. So we got about a year and a half to get this sorted out. Thanks for that question, Wendy.
And if you are at any of the conferences that they're going to be having on the Medicaid waiver expansion and you see Commissioner Steckel there, please stand up and thank her for that. The HANS multigravida language has been on, I can think of 3 Medicaid commissioners' desks, and she is the first one to have acted on that. So we are most grateful for her attention. It was not a hard sell for her to understand how critical this is. Other questions for Dr. Howard?
All right.
Well, I know he's very articulate, but I'm sure somebody must have a question. Okay. All right.
Thank you.
Well, these slides will be on the nurse website, so you'll be able to go on the website and find this. Yeah, you need your zip drive. Okay. So you'll be able to go to the nursing website and you'll be able to find this information. Okay. Thank you. So I just want to, in summary, go over some other things that are important for you to know. And it's kind of a little bit jumbled, but we're going to go through some important dates and times. Before we go through this, though, I do want to say, I know that Dr. Blau showed the screen. They had the picture of all of the syringe exchange programs in Kentucky, but that screen was 5 days old because since that picture was made, we want to congratulate our folks in Green River Health Department District, and particularly the people at the Henderson County Health Department, as they now have had all the approvals for them to have a syringe exchange program in Henderson. So we are extremely excited about that for that group. The thing that is not on this slide, and since I'm kind of in charge of this meeting, I can't believe I forgot to put it on there. Number one, April the 9th, that is when the Harm Reduction Summit is going to be held in Northern Kentucky at the Northern Kentucky Convention Center. It will be the day before KPHA starts. There are blocks of rooms. I was just talking to Kelly, and hopefully by tomorrow that link will be sent out, and it'll be a link on our website which will have registration. We do insist on you registering just so we know how much food to buy, and for anybody who's planning the meeting, you know how important that is. There's also going to be a link to hotel rooms. We encourage you to get those rooms as quickly as possible because the Reds are going to be playing that week in Cincinnati, so those rooms will fill up if you don't get into that block. While we're talking about, let me just go back to two keynote speakers. If anyone went to the syringe exchange program last year and heard Dr. John Zabel speak, he's an absolute expert on all things substance use disorder around the country. He's a medical anthropologist, and he is just a crackerjack speaker, so you will not be disappointed by Dr. Zabel. At noon over our lunch, and we will have free breakfast, free lunch, and free parking, we are going to have a visit from Austin Eubanks. A visit from Austin Eubanks. He was a survivor of the Columbine shooting. He was shot at Columbine, and because of some surgeries he had, he became addicted to opioids, and then that turned into, as it often does, into multi-drug addiction. So he is going to be our speaker at noon. We will also have the naloxone trailer available that morning at 7 to 8. The meeting starts at 8 for free naloxone distribution. And you will also have naloxone distribution from 5 until 6. So that's all in the flyer, and you'll be getting that soon. KPHA then starts the next day, and we are going to have Austin Eubanks also do the opening for that meeting. He will be doing 2 different talks, so you're welcome to come and hear him at both places. Normally we would have our public health nurses luncheon at noon on Wednesday, but we are very honored to have the president of the American Public Health Association will be at our KPHA meeting on Friday, and her name is Pam Alatone, and I'm probably murdering that pronunciation, but she is a public health nurse. So I felt like as we try to continue the tradition of honoring our public health nurses, having the most important public health nurse in the United States in our own backyard, we can move that from a luncheon to a breakfast on Friday morning. So you will be getting information about that as well. But we're very excited to have the president of KPHA agree to meet just with our public health nurses and do a breakfast with them. Other things that are listed up here, the NEC last month passed some CCSG changes that I will be getting out pretty soon, and you'll be seeing those. They have mostly to do with hepatitis A and hepatitis C. APRN conference, we are planning an APRN conference this fall. And so we don't have a date. I'm going to try to do that in September instead of October because I want to be sure that if something happens and you break your leg and can't go to the October meeting, you don't have a real short window to get your CMEs. So we're trying to do that in a September date to make it easier for everyone. Soon you will be getting a notification of a release of the neonatal abstinence syndrome report and the diabetes report. That will be coming out with a lot of really good data and information that will be helpful as you're looking at your environmental scan and at your data in your community and you make your health assessment, community health assessment Dr. Howard was speaking of. We are actively seeking a new chief nurse, public health nurse for the department. I know it is frightening for people to think that I'm serving that role, but trust me, it is an acting position. I have no intention of thinking I could even begin to lead the great work that y'all do, but I am very committed to our nursing staff, and I'm very committed to be sure that the services, the meetings, the education that we normally do continues until we get someone in that position. The good news is that the commissioner has decided instead of having a leader who is half public nurse officer and half director of the Division of Women's Health, we are now going to have a chief nursing officer. So that position will be a full position dedicated just to your work, and I'm extremely excited about that. Our next public health webinar, like I said, it's not an ITV, is supposed to be April the 10th. That is the first day of KPHA, so I'm going to work with our folks here to record the public health nurse breakfast, and we will be sending that out. So we won't have a public health nurse webinar in April. We will have it at the breakfast on Friday. And then I'm hoping, if we can work it right, we will have that for view by noon. So the nurses that do have to stay at work, can't come to KPHA, at least that morning after the breakfast, they can sit down over their lunch when they're sitting at their desk if they want to, and they can watch this message, or they can watch it at any time that they want to. I did want to make sure that you were all aware of the April 18th Annual Women's Health Update. That's a 3-hour required program for the KWCSP, and that's coming up, and I've seen their list of speakers, and they've got some great folks coming in that are going to be very helpful as we work to care for the women in our communities. And also wanted to be sure that I would hope everybody got that listing from Rhonda McGuire in Madison County. The registration is now available on Train for their first comprehensive reproductive exam training and STI training, March the 7th. So you need to go to Train. There are several dates that they're going to have these trainings: March 7, June 6, October 10, February 12. That's all in her email. If you did not get that, please let me know, and I'll be sure that you get that forwarded to you. As we look at the website, it lists the members of the Nursing Executive Committee from 2013. There are nothing about our webinars since 2014, I believe. The nurse leader list that was on the website from the health departments is incorrect. I keep getting people saying, gosh, I haven't heard from the chief nursing office. If you didn't get anything about this webinar, anybody, if your chief nurse in your area didn't get this, please let me know. We're going to have to rebuild that list. We're going to have to rebuild the APRN list because we can't seem to find that. No one at the Office of Technology has any idea of what I'm talking about. And I know that used to exist. It doesn't now. We're going to rebuild it. So please be patient with me. The first thing I learned when I set this up was I realized I didn't get CME for this. So I appreciate those of you who sat through the morning not getting CME, but I think you learned a lot of very valuable information. So we will not have a public health nurse CME or a public health nurse ITV webinar next month, but you will be getting a recording of the president of APHA as well as CME for that. And I do hope that a lot of you can come on Friday, that would be the 12th, to hear her do her breakfast presentation for our public health nurse staff. Colleen, did you have something?
I just wanted to make sure that we were clear on the annual women's health update in April. And that one will have CEs with it.
Yes, that the annual women's health update, that 3-hour training I talked about on the 18th, will have CEs. So if you have questions, let me know. We're going to start working right now on getting this recording posted some way that you can get to it and getting the slides on the website. Thank you for your patience. Thank you for your attendance, and we will reconvene with an official webinar that will be June. And by that time, I'm certainly hopeful that we will have a chief nursing officer, and we will allow her or him to continue these meetings in a way that works best for you and your needs out in the field. So thanks, everybody. We appreciate your time today, and we'll talk to you soon.